So Beatrice has already spoken to us earlier on this morning. Happy to reintroduce her to talk about pathways to training in transplant ID.
Hi, everyone. Again, it's me back again to talk about another thing I'm passionate about. And in this particular case, it's training transplant ID physicians. I will signpost two things before I begin. One, that this talk is aimed primarily at registrars finishing their training and wondering what's next. And two, it's actually nearly 2 in the morning here, so I fear that my brain will work more slowly, though I cannot promise that will mean that my speech will be less pressured, but I will do my best. So I guess to start with, just to give a bit of of context about the training pathway that I've personally undergone, here's a Google Map plan of all the journey that I've taken thus far. All in all, it's been about 5 cities and at least about a 48-hour straight drive if one were to drive it continuously, which is unfortunately probably the kind of thing that I would try to do. Google Maps did balk at the idea of driving into the ocean. Although perhaps I did not at some points in my training. So the overseas part of it is neither here nor there. So I started my ID training up in Cairns, and then came back to the PA in Brisbane, where I'd done the bulk of my residency and my BPT training. At the end of my second year, two things were true. One, you still had to do a 6-month micro job. And two, I had no idea what I was going to do when I, as a single college ID registrar, didn't get one in Queensland. Fortunately, my partner, who is a nephrologist with significantly more executive function than me, decided that he wanted to go to Adelaide to get another year of transplant nephrology training. And through a long and complicated comedy of errors, I did end up getting a job at the Royal Adelaide Hospital, doing 6 months micro and another 6 months of ID training, and then was sorted for another year. At the end of that year, though, I found myself back in a very familiar position, and that was not knowing what to do. I had always wanted to dual train in immunology and infectious diseases, and had actually taken the path to get one of my ID years accredited as an elective immunology year. But the idea of having to learn an entirely new specialty, that breadth of knowledge required to be on top of two specialties, that was entirely too daunting for me. So on a whim, I actually applied to the Peter Mac for their Immunocompromised Host ID Fellowship, which at the time, and to my knowledge in any case, was the only one being advertised in the country. And I ended up being there for the next 18 excellent months. But I wasn't going to be caught unaware yet again, or in yet another existential crisis. These are lies. While I was in Adelaide, I had actually noticed there were a significant number of trainees who would go away to do an international fellowship and come back with interesting job titles under their belts. Transplant ID physician was one. NEDM editorial fellow in the case of my then consultant, Matt Roberts, was another. And what better time, I thought, than now to go away and do something fun like that? When would I ever get a chance to do that again? And that's how I ended up here at 2 a.m. in North Carolina. Record screech. Um, what I'm trying to say is that while I've been lucky enough to work in some amazing places and with some amazing people, none of my journey has been particularly planned. Everything has been a bit improvised and more than a little bit of luck. I've never felt that I've had a clear path. I've never 100% felt that I've known every single option that was available to me. And I guess part of the reason I'm so keen to speak on this today and always is because I feel like it should be that easy. And that's what I hope to make it be for trainees coming up through the program. So why should you, as a bright young trainee, go away to do more learning and doing another fellowship? Look, I'd argue that's lots of reasons, but these are my top 5 in no particular order. First and foremost, to get specialized and dedicated training, in my case, in transplant ID. Working at the PA through my training, I was really fortunate that I had really great exposure to transplant patients, their infections, but my learning, I felt, was almost in a very incidental kind of way. I think in Australia, we're really, really good at clinical training, but less so perhaps at more didactic or more dedicated teaching. Certainly, I didn't feel like I had a good handle on patients with allogeneic transplants, nor did I particularly understand how CAR T worked. Probably could have helped if I had come to a conference like this, or what to be worried about. And the nuances of transplant ID were perhaps lost on me in one of those unknown unknowns kinds of ways. Number two, to get more research experience and wider research opportunities. One of the big draws for me was the research aspect of the Peter Mac job and later here at Duke. I think there's a lot to be said about research infrastructure, and that's something I feel like I've learned a bit later. It's a lot easier to do research when people around you are doing research as well, not to mention inspiring. Three, to be exposed to different systems and different clinical practices. Even though I think this, variation between individual practitioners locally, would argue that we all generally practice ID with very similar brushstrokes. Though I think once you zoom out and leave your state, the variation in practice becomes a bit more obvious, and even more so when you zoom out further and leave the country. Not only that, I think the availability and exposure to some of the medications and tests that are available here in the US have really quite blown my mind. I recall crowing to one of my friends on a WhatsApp chat last year that I, was using Tadalafil for the first time, and he replied, "Ugh, I think you spelt linazolid wrong." Um, Four, networking. So I think similar to the research aspect, the networks you get access to by moving around are really invaluable. And I think it's extremely important in all aspects of a career, whether it's because, I might in the future want to send a trainee to a fellowship in the US or in Melbourne, or maybe I, want to do a multi-center study, or even something as simple as, phoning a friend about a difficult infection. I cannot really speak highly enough of the role of a fellowship in establishing those links. And finally, I think travel is also a really important consideration. You go through so many years of training, you study for so long, do so many exams, and I think it's really valid for travel to be a big motivator in picking a fellowship as well. Because, as I said in the other slide, what other time of your life are you going to be able to do something like this? So I've listed my top 5 reasons to do a fellowship here, but I think the important thing to note is that for you personally, they're not all weighted equally. What's important to me isn't the same as what's important to you. And I think that's probably the first thing you need to consider when you're picking a fellowship, because not all fellowships prioritize any of those 5 points equally. And it's important to know what you want of it before you go into it so that you can pick the right one for you. Um, Unlike some places internationally, I don't think we have a dedicated Transplant ID training pathway, but there are still opportunities and places that you can go for an additional year of training in specialized areas. On the transplant ID side of things, these are the domestic fellowships that I'm aware of. I've taken this from a database that I compiled as part of my role as the ACIT Recent Fellow Rep. And this was submitted, all these fellowships were submitted through the AusBug community. So I put the link up there. There are other ones that are non-transplant ID related, TB fellowships and things like that. So anything of interest, there are lots of contact details up there. I can specifically speak to the Peter Mac Fellowship. That's a year-long immunocompromised host clinical year, where you exclusively see patients with hematologic and oncologic malignancies. And these patients are often undergoing very specialized trial medications, most of which I personally had very limited experience in, so that was really good learning. They take both registrars and fellows, and I did it in my 4th year, so after I got my FRICP, which meant that I had more flexibility to split up my year and intersperse the clinical side of things with a research fellow role, and that gave me a lot more clinical trial and personal research exposure. I can't speak specifically to the other fellowships, but in discussions with other friends and consultants who are there, they sound very similar. And once again, I've included contact details of people who are happy to be reached out on that database, and you can find them at that link. Internationally, transplant ID is a bit more of its own specialty, with physicians, at least in North America, streaming into either Gen ID versus General ID versus Transplant ID. And for the purposes of Transplant ID, Canada and the US are probably the 2 places that are most frequented. Canada is appealing because you don't have to do an exam to go over there unless you want to stay. And there are 2 main places that Australian trainees have been, or the ones that we know take Australian trainees, and those are Toronto and Alberta. Vancouver seems to have less of an advertised transplant ID program, but I know for a fact that it does take Australian nephrology trainees, so potentially that could be one worth reaching out to if you were particularly keen on Vancouver. For the US, that requires at least step 1 and 2 of the USMLE at most centers. Though I have to say it's quite a bit less insurmountable than I actually expected it to be. The advantage of it is that there's a very strong program and so many more centers than in Canada, and quite a lot of them do take Australians. Recent and common spots that Australians have gone to are Duke. Obviously, I'm here, but also Mass Gen and UNC, though certainly there are more. That picture on the left there is a list of all the hospitals that offer transplant ID training, and that's on the American Society of Transplantation, the AST website. Not all of them take Australians, but that's where I started when I began planning my fellowship. Um, I think the advantage of these North American programs is that the infrastructure for transplant ID is already set up and they're used to fellows. And in the case of those three places that I've listed there, they're used to Australian fellows specifically. And the programs are often really big, which means not only are you forming networks and links with your mentors above you, you're also forming links with other fellows who will be your peers and people to bounce ideas off and collaborate with in the future. Some practical considerations that I've kind of already touched upon. I think the most important thing is to know your timing. A lot of the paperwork to move internationally obviously takes a really long time. For me personally, I started the process about 2 years before I was planning to go. I don't think you necessarily need that long. I'm just a very anxious person, but it was really useful to have that additional time to get everything certified, get your visa appointments, all your ducks in a row, etc. The other part of this also the licensing exams. The USMLE, for example, was only being held in Melbourne and Sydney when I had to sit it, partially due to COVID reasons. And step three, if you have to do it, has to be done in the US. So all of that takes some planning, but is very doable. Um, and just another thing to note, the US is a centralized system as well. So even if you get your job separately, which most of these transplant ID fellowships are, you do have to make sure that you apply to the right pathway or the match, even though you're not getting your job through the match. It makes no sense, but it is what it is. Funding, when you meet with the program directors, they'll be pretty upfront about it, but some fellowships, if I recall correct, Johns Hopkins, particularly required you to bring your own funding, which is not so possible when you're a registrar, just finishing up your training. Um, Visas is pretty straightforward for Australian citizens. There's an Australian specific visa called the E3 visa, which is routinely underused. It's good because it doesn't have a time limit on how long you can be there, although it does need to be renewed yearly. But there are lots of people on it. There's a Facebook group called Australians in New York or something like that, where people list embassy appointments in lovely beach places around the world where you can go wait to get your visa renewed. And the other good thing is that if your spouse comes over on your E3 visa, they are also able to work. Um, and I think that's also a really important point, family and partners. It was really actually surprisingly easy for us to find a place that would take the both of us. Actually easier than in Australia, where my partner and I had spent alternate years doing long distance. And I think that speaks a lot to knowing your value because a lot of these places actually want Australian trainees because we come to them having already had clinical experience in training. So we're actually pretty valuable in their service. So um, know what you want to do and know that they want you to. So this is my how-to guide. That was my personal process. So I started, as I mentioned, on the AST fellowship database, and compiled a list of all the fellowships that would take Australian trainees. I reached out to some people at Being Overseas. My director at the time, Jeffrey Playford, had put me in contact with Dave Patterson, who was at Pittsburgh. Spoke to them, spoke to Matt Roberts, spoke to a bunch of people I knew who had been over there. Then I made a list. I ranked it out of whether it had fellowship opportunities for both myself and my partner. And then on a scale of 0 to 2, how much did I actually want to live there? After that, I just cold emailed a lot of directors and then the interview sort of just came pretty quickly thereafter. And so I think that's probably a pretty good guide as to how it all works. But the only other thing is that please feel free to reach out or send trainees my way. I personally love yapping, and I especially love yapping with a purpose, though I don't often do it. So I'm so very, very happy to help or point in the right direction or to someone who can. So these are sort of a list of resources. I've mentioned the ACID Fellowship Database and the AST Transplant ID Fellowship Database. They're my two starting points, but also definitely be aware of your local context. So once again, happy to be contacted. Kathy, I'm going to dob you in. Kathy's in the room at the moment, presented an amazing talk before. She recently got back from UNC. And if I'm not wrong, I think Julia Clark potentially also went to the on a fellowship somewhere. And Dave Patterson was the other person I reached out to as well.
Thank you, Beatrice. That was absolutely amazing. Um, you're not that anxious, surely. It just takes years and years to do these things.
Bit of both.
I really appreciate it. I hadn't realized it was 2 o'clock in the morning. So I think all of us need to say thank you very much and go to bed.